Colposcopy is just like it's a low-post stereoscopic binocular microscope useful in getting a magnified vision of the cervix. And contrary to the popular belief, it's not a screening technique, it's a diagnostic procedure with a goal to identify precancerous and cancerous lesion. So, coming to the need for colposcopy. CSF6 now also it's an unmet challenge. In India, after CA, breast cervix is the most common cancer in females, with India bagging around 23% of new cervical cancers in the world and around 25% of deaths due to cervical cancer in the world. So, what are the indications of a colposcopy? First of all, I already covered the screening positive. If screening is positive, like if it is positive cytology, positive HPV DNA, or positive VA, whatever be the screening technique, if it is positive, next step is colposcopy. Then, second indication is evaluation of unhealthy cervix. And third one, if you want to take a biopsy, if you want to guide it or to do a treatment of a pre-malignant lesion, then do colposcopy. So, what if it's a screening test is a cytology? What if it is LCL or more? Go for colposcopy. If it is ascus, being a low-grade lesion, ascus, next protocol is to go for an HPV testing. And if HPV is positive, then go for colposcopy and do a biopsy. And if HPV testing is negative, then we can do a follow-up with pap smear after 6 to 12 months. What about HPV DNA testing? This is a major difference between 2012 ASCP guidelines and 2019 ASCP guidelines. In 2012 ASCP guidelines, if the primary high-risk HPV, if the HPV testing detected positive for 16 to 18, then go for colposcopy. If it is 12 other high-risk HPV, then they recommend cytology. What they utilize the term is reflex cytology. Like I already told that in liquid-based cytology, we are using the resultant fluid for preparing, for HPV DNA testing. That is called a reflex HPV DNA testing. Here this thing, we are taking the sample, dispersing in the fluid in that HPV DNA bottle, and if the result comes as 12 other high-risk HPV, then the same fluid is utilized for preparing a slide. That is called a reflex cytology. And based on the cytology, if it is anything more than ascus, go for colposcopy. If it is NILM, then we can give an option of follow-up in 12 months. But this is the latest 2019 ASCP guidelines, which recommends whatever be the result, 16, 18 or 12 other high-risk HPV. There is no role for reflex cytology. Go for colposcopy. So, if visual methods are positive, like visual inspection showing some acetic acid positive or leukocyte positive lesions, go for colposcopy. And coming to the anatomy of cervix, this is the endocervical canal lined by single layer of columnar epithelium. At the transformation zone, it is converted into multi-layered squamous epithelium. This is a normal colposcopy of the cervix. Here we can see the red-colored columnar epithelium. This is a squamo-columnar junction, with this being the transformation zone. About the origin of transformation zone, once a female child is born, the endocervical canal is completely lined by columnar epithelium, and the squamo-columnar junction lies at this area. This will be lined by squamous epithelium. As the child grows, the endocervical columnar epithelium will grow outwards. So, this much area will be covered by the columnar epithelium, and this will be the new squamo-columnar junction. As the child attains puberty, the vaginal pH changes. It will become acidic. And once this acidity causes, what happens? This area, in this, the exposed areas undergo squamous metaplasia. And the squamous metaplasia will grow into this area. So, this will be the old squamo-columnar junction, and this will be the new squamo-columnar junction. And in between these areas is the transformation zone, where there is active multiplication of squamous cells and where HPV viral infection is very much prone. So, this is the colposcopy showing inner red columnar epithelium, new squamo-columnar junction. If we see clearly, we can see the outer squamo-columnar junction. How will you identify the outer squamo-columnar junction? Because in this picture, this is also pink, this is also pink, this one might be red. How will you differentiate a outer squamo-columnar junction? So, through this squamous metaplasia, we can see the crypt openings of the underlying columnar epithelium. Through this squamous metaplasia, we can see the crypt openings. By drawing an imaginary line joining the outer crypt openings, we can identify the outer squamo-columnar junction. This is an imaginary line join, outer squamous-columnar junction. This is the columnar epithelium. This is the new squamous-columnar junction. In between is the transformation zone. So what are the types of transformation zone? There are 3 types of transformation zone. On putting the speculum itself, we can see the inner columnar epithelium, new squamous-columnar junction, old squamous-columnar junction, then it is a type 1 transformation zone. But if only you can see the inner squamous-columnar junction, like new squamous-columnar junction by manipulating, by putting an endocervical speculum or a Gucci, then it is a type 2 transformation. Even if with the manipulation you can't see a new squamous-columnar junction or columnar epithelium, then it is a type 3 transformation zone. What's the significance of this? Identifying the types of transformation zone. Like, we need to decide the excision of the, while we are doing a leap, we need to do an excision procedure depending on the type of transformation zone. If it is a type 3 transformation zone and we are doing just a type 1 excision, we might miss a lesion inside. And always it is better to do an endocervical curating if it is a type 3 transformation zone. And another type of transformation zone is congenital transformation zone. Like, if in the posterior lip, the outer squamous-columnar junction is extending into the posterior fornix, then it is called as congenital transformation zone. This is a type 1 transformation zone. Without any manipulation, we can see the inner columnar epithelium, new squamous-columnar junction, and the outer squamous-columnar junction can be seen here. So it's a type 1 transformation zone. Here, only with manipulation, by putting a Gucci, and we can see the columnar epithelium and the new squamous-columnar junction. That's a type 2 transformation zone. In this thing, even with manipulation, we can't see anything. That's a type 3 transformation zone. Then what is Nabothian cyst? Through this squamous metaplasia, we can see the crypt openings. If this crypt openings of this columnar epithelium get blocked, that will be seen as Nabothian cyst. So how will you do a colposcopy, or what are the procedures in colposcopy? First of all, after adjusting the colposcope, ideally the lens of the colposcope should be at a distance of 30 cm from the cervix. First of all, we have to adjust the focal length, position the colposcope, then do an inspection of the cervix. After saline swabbing, then do inspection with the 3 to 5% acetic acid. Again, inspect cervix with Lugol's ID. Colposcopy can be also done for vulval and vaginal procedures. And the important points to be remembered as that it is an OPD procedure, no need of anesthesia, no need to take the patient to OT, no need for patient to come on empty stomach. It's a comfortable, relaxed position. And the total procedure takes around just 5 to 10 minutes. Privacy should be adequately maintained and bladder should be empty before taking the patient for procedure. So the images of colposcope, and these are the colposcopy tray or instrument should contain all these things. Ideally, different sized speculums, Sim speculum, Cusco speculum, artery forceps, endocervical speculum, valsellum, sound diffusory, and punch biopsy forceps, and different sized Guccis, saline, acetic acid, Lugol's iodine, specimen bottles to be there. And this is the Cogan's endocervical speculum. If we are not seeing the columnar epithelium, we can introduce this Cogan's endocervical speculum and assess whether it is a type 2 or type 3 transformation zone. This is tissueless punch biopsy forceps. Just look at the tip. So this is tissueless punch biopsy forceps to take biopsies. So steps of colposcopy: after careful inspection of vulva and perineum, introduce the speculum with adequate lubrication. Look for any ulcers or tumors. And after taking a picture, if it's a video colposcope, nowadays all colposcopes we can take images. So after taking picture of a normal speculum, we can put on the knob on the green filter. So what's the principle of green filter is that on a green background, we can see the vessels as in black color. So we can see the vessels better in a green background rather than the red vessels in a pink background. With normal colposcopy, everything is pink. In that thing, it's difficult to identify red vessels. So utilizing green filter, we can visualize the vessels. So the normal vessels can be of any pattern. This will be the imaging of a normal capillaries. Atypical vessels, like we all know, once there is malignancy or pre-malignancy, the branching patterns will change, the caliber of the vessels will increase, and these will be seen as different patterns like hairpin, waist thread. See, this is an imaging of an atypical vessels. It's more in favor of pre-malignant lesions. In normal colposcopy, what we are supposed to see is an original squamous epithelium squamous epithelium, columnar epithelium, and transformation zone. Then after visualizing, apply the green filter, take the image. Then again, apply 3 to 5% of acetic acid and look for acetovite lesions. And I already explained the principles of acetic acid application. And this is a normal squamous epithelium. After applying acetic acid, there will be a mild acetovite change, not that much change, and glandular crypt openings can be seen. Nabothian cyst is a normal finding, and usually in postmenopausal cervix, there will be pale, thin, ectopic epithelium with the transformation zone retracting to the endocervical canal. And for coming to abnormal colposcopies, after applying acetic acid, we can see acetovite lesions. Depending on the amount of abnormalities, it can be thin acetovite to dense acetovite lesions. So always document the site of the dense acetovite lesion, like whether it is from 3 to 4 o'clock position, 5 to 6 o'clock position, or it is inside the transformation zone, outside the transformation zone, whether it is extending into the fornix, or if it is extending into the endocervical canal, or if there is just a skip lesion, like nothing is there in the transformation zone, it is something outside the transformation zone. Document all these things. And document the size of the lesion, like 5 millimeter lesion, 5 to 10 millimeter lesion, or 10 millimeter lesion, like the documentation should be proper. So document the degree of acetovitening, like dense acetovite or pale acetovite, shape of the lesion, border should be mentioned, whether there is a raised border or a flat border, and the contour. And here I think you can see the acetovite lesions here. These are geographical acetovite lesions. It's a dense acetovite lesion. This is the endocervical canal. And in colposcopy, the major lesions will be characterized by dense acetovitening, sharp borders, raised margins, and it will remain longer. If it is a minor lesion, the acetovitening will disappear soon after application. So we have to repeatedly apply acetic acid and look for the appearance of acetovite lesions. So usually vascular patterns will be absent versus punctuations and mosaic patterns is the vascular pattern we see in colposcopy. Punctuations is a end-on view of this capillaries, like the end of the capillaries we are visualizing through this squamous metaplasium. It can be fine punctuations or coarse punctuations. This is a coarse punctuations which is suggestive of a high-grade lesion. Again, coarse punctuations suggestive of high-grade lesion, coarse punctuations. Mosaicism, because of this dense vascularity, we can see this squamous metaplasia as mosaic pattern. Again, which is of fine mosaicism and coarse mosaicism. Fine mosaicism is more in favor of low-grade lesion, and coarse mosaicism is in favor of high-grade lesion. This is a picture of coarse mosaicism, coarse mosaicism, coarse mosaicism. And this is Lugol's side, Schiller's testing. After application of Lugol's side, normal cervical epithelium rich in glycogen won't take up the iodine. They will seen as mahogany brown. The other areas will stained into mustard yellow. This is the mustard yellow discoloration. The endocervical columnar epithelium, due to lack of glycogen, they won't take up iodine. It will seen as mahogany brown color. So don't misunderstand it as a lesion. This is the endocervical canal. This transformation zone, always look for the transformation zone discoloration. So always document it properly. This is a IFCPC 2011 documentation. Always document like SCG visualization, whether it is a partial or complete visualization, whether the visualization is adequate. Like if there is inflammation or bleeding, we can't see the SCG. So document it properly. And whether you can see the original squamous epithelium, columnar epithelium, type of transformation. All these things has to be documented. And document whether the lesion is inside the transformation zone, outside, and how many cottons of the cervix are involved, whether it's a dense acetovite lesion, whether there's coarse mosaicism or coarse punctuations are there. Anything suspicious for invasion like atypical vessels, fragile vessels are there. And look for any miscellaneous findings like erosion, inflammation, endometriosis or polyp. So, document the normal findings. Always document the abnormal findings like whether it is inside the transformation zone or outside the transformation zone, size of lesion. Usually major lesions will be characterized by dense acetovitening, rapid acetouptake, coarse mosaicism and coarse punctuations. These were certain specific signs documented in 2011 IFCPC, and if these signs are present, it is more in favor of a major lesion. One is a cuffed glandular opening. This is a normal glandular opening, but this is a cuffed glandular opening. On the opening of the glandular openings in the columnar epithelium, we can see like a cuff. It is more in favor of a major lesion. Here you can see a cuffed glandular opening. This is ridge sign. Ridge sign means in that aceto-white lesion, one area will be seen as a sharp, distinct protuberance. This is a protuberance. This is called as ridge sign. It is also in favor of major lesion. Here you can see a ridge sign. That is another protuberance of dense aceto-whitening, ridge sign. Another one is inner border sign. Inner border sign is in that aceto-whitened area, one area will be distinctly prominent compared to the other aceto-white areas. This one. This is an inner border sign. If there is an inner border sign, this is also more in favor of a, here you can see the distinctly dense aceto-white lesion in a background of faint aceto-white lesion. It's the inner border sign. Another one is rack sign. Here, on applying the acetic acid and saline itself, there will be peeling of this cervical epithelium like mucus coming out. It's not like mucus, specific peeling of the cervical epithelium. That is called a rack sign, more in favor of a major lesion. So, suspicious of invasion will be atypical vessels, fragile vessels, irregular surface, exophytic lesions and ulcerations. And definitely carcinoma will be characterized by atypical irregular vessels. And as colposcopy is basically a subjective examination, certain scores were introduced to improve the sensitivity of colposcopy. Initially, Reed score was introduced based on the color of aceto-white area, margins, vessels, and iodine staining. Then later, Sweet score was introduced by adding the lesions criteria to improve the sensitivity of Reed score. But after the Altis trial, the sensitivity of both the Reed score and Sweet score were around 5 to 7%. So in 2011, IFCPC introduced this new scoring system as minor lesion and major lesion to improve the sensitivity of colposcopy. So, is there any contraindication for colposcopy? No absolute contraindications. Treat active cervicitis before examination. If the patient is on clopidogrel or ecospirin or some bleeding diathesis, it's not a contraindication for biopsy. There were non-specific lesions like leukoplakia or condylomas. This is a strawberry cervix, typical of trichomonas vaginal infection. This is a strawberry cervix after leukocidin application. This is a condyloma. These are miscellaneous things, leukoplakia. And once we have seen or localized the high-risk areas, like after applying acetic acid and leukocidin, we know which are the sites of high-risk areas, like which are the dense aceto-white lesions or which are the leukocidin negative areas. Go and take punch biopsy using a tissueless punch biopsy forceps. Select the most severe lesion using sharp instrument, take a 2 to 3 millimeter biopsy, and usually take a biopsy from ECG. If there is bleeding, you can apply Monser solution. If there is no Monser solutions, in order to control bleeding, just keep a pack. So the benefits of colposcopy is a non-invasive, no anesthesia is needed, helps precise examination of cervix and transformation zone, helps in taking a guided biopsy, OP procedure, no need of anesthesia, no need of OT, and easy to follow. Thank you.